Exactly. Thank you very much for the kind introduction, Massimo. Thank you very much to the organizing committee for the invitation. So today I will focus on cccDNA transcriptional activity and biomarkers. So why do we need a biomarker for cccDNA transcriptional activity? So when you talk about cccDNA is a dynamic epigenetically regulated molecule. So we have to talk about the quantity of cccDNA, but also how many RNA molecules are produced from each cccDNA molecule, which is the transcriptional activity. And this transcriptional activity can vary across the natural history of chronic infection, but also potentially during antiviral therapy, as we have demonstrated in long-term tadbudin treated patients whose cccDNA acquire negative epigenetic marks and have less amount of progenomic RNA. So when we talk about functional cure, we are aware that cccDNA is still on the liver, but we want to be sure that it's functionally inactive, so the transcriptional activity is no more there. So the gold standard, of course, is to look at the liver, to quantify cccDNA and transcriptional activity, but with obvious limitation of the invasiveness, sampling bias, and technical challenges. So to have a non-invasive biomarker would be really helpful for that. So correlated antigen, where does it come from? It is translated from overlength HBV RNA pregenomic and pre-core, and so only produced from cccDNA, and it recognizes the core protein and HBe antigen and the pre-C or P22CR, which keeps the N-terminus but lacks the CTD. So we have one available assay, commercially available assay, which is the CLIA correlated antigen assay kit from Fujirebio. And this is the kit that is available in Western countries. It has 3 steps: a capture, a pre-treatment with detergents with also dissolved immune complexes, and a detection step. And the LOQ is 2.8 log units per ml. So there's another test that has been recently published, but is only available in Japan so far, and it is almost 1 log more sensitive. So it's clear that correlated antigen is positively correlated to the cccDNA pool in the liver, and it is well summarized by this meta-analysis study. But very few studies looked at the intrahepatic cccDNA transcriptional activity and correlated antigen. The first one was by Honda and colleagues, who showed that in an Asian NUC-treated CHB patients cohort with patients who were positive for correlated antigen had higher intrahepatic RNA, but similar levels of cccDNA. And we had the same results in a Caucasian cohort of untreated patients. So patients having the same amount of cccDNA being negative for correlated antigen had less RNA in the liver and less cccDNA transcriptional activity independently of E antigen status. Moreover, correlated antigen was highly correlated with both RNA and transcriptional activity in the liver, in the overall cohort, and particularly in the HB antigen negative patients. But more interestingly, when we looked at the unsupervised principal component analysis, you can see that correlated antigen was able to identify a subset of E antigen negative patients in pink in the left below panel that you can visualize in the heat map, and these patients had the highest levels of transcriptional activity among HB antigen negative patients, and also high fibrosis and necroinflammatory activity. And importantly, these patients couldn't be identified looking at serum HBV DNA and HBs antigen alone. So to summarize, correlated antigen correlates with cccDNA transcriptional activity, might help in discriminating more active HB antigen negative patients, but it's limited in the use of HB antigen positive patients because it also recognizes E antigen. And in our study, 1/3 of the patients, HB antigen negative patients, were negative for correlated antigen, but they all had transcriptionally active cccDNA in the liver. So probably we need for much better sensitivity for this assay. As a footnote, correlated antigen has been validated using dried blood spots, so it can be implemented in the resource-limited settings. This is very important because the technique is minimally invasive, doesn't need cold chain, is genotype independent, and really can help identify viremic individuals who need antiviral therapy in this setting. So going to serum HBV RNA, so here comes the troubles, the complexity. So serum HBV RNA can come from cccDNA, but also from integrated sequences. So 3.5 kb RNA is only transcribed from cccDNA, and it has been shown that encapsulated pgRNA is the predominant form of circulating HBV RNA. So the first studies looking at serum HBV pgRNA were done using qPCR or digital PCR in this region of the RNA, which is at the beginning of the pregenomic RNA. And this is a region which is not shared with the other transcripts. And Wang demonstrated in 47 Asian nuc-treated patients that this quantification correlates with the intrahepatic RNA and cccDNA transcriptional activity. The group of Maura Dandri demonstrated the same in a humanized mouse model, also demonstrated that serum HBV RNA was not affected by nuc treatment, but was decreased by interferon, which is known to decrease the cccDNA transcriptional activity. And then Wang again also demonstrated this correlation in treatment-naive Asian patients. But since then, a number of publications demonstrated the complexity of circulating HBV RNA species. So not only pregenomic RNA, a lot of splice variants that can really vary in quantity and heterogeneity across phases, a certain heterogeneity at the 3' end of these RNA that can be truncated, polyadenylated or not, also in correlation with nuc treatment, the presence of HBx RNA, and also the fact that capsids and virions were not the only shuttling elements of RNA in the serum. But also a complexity of the serum HBV RNA assay that has been used across all the studies that have been published. So it's really difficult to catalog all of them. So a heterogeneity in the primers and probes that were used, heterogeneity in the techniques used, but I want to really make a point on two commercial RNA assays that are now available. So the first one is the Abbott one, which was the first to be described. So it is designed with the two set of primer and probes, the one in a conserved region within the 5' end of the X gene, and the other one in the 3' end of the core gene. These two targets, very important, are independently detected, meaning that they are not necessarily on the same molecule when they are detected. It's genotype independent, and the calibration is done on a DNA standard. So Abbott demonstrated that the results for the X and core target was really comparable among all the patients that they analyzed, both nuc-treated and untreated, and also in longitudinal individuals. So the second assay is a Roche HBV RNA investigational assay for the COBAS system. In this assay, the primers and probes are located across the 3' end canonical polyadenylation signal, which is lost in integrated HBV DNA. Just theoretically recognizes only RNA coming from cccDNA. So the assay doesn't need any DNase treatment before the quantification. It's validated across genotypes. It gives the same results in serum and plasma. It's completely automated, but a manual assay is also available for laboratory testing and has the same efficacy of the automated one. So the COBAS is calibrating on an armored RNA, which has been quantitated by digital PCR. So the two tests were compared to an in-house race PCR, which was developed by Van Bommel in 2014, and both of them showed a good correlation with this in-house PCR and superior sensitivity. However, a comparison between the two Abbott and Roche assay really needed the implementation of an international standard for HBV RNA. In this context, we are working toward it together with Massimo, and we were able to establish the clonal cell line secreting high quantities of HBV RNAs. These cell lines has mutations in the pol operating frame in reversing the ratio between HBV DNA and RNA, and the majority of this RNA is contained in virion and NAT capsids, and single-cell molecule sequences demonstrated that this RNA is majority pgRNA and xRNA, and this assay is suitable for usage on the Roche automated and manual assay. So we extensively validated the correlation of the Roche assay with intrahepatic cccDNA transcriptional activity in a cohort of 100 untreated chronic hepatitis B patients. I show you, for the sake of time, only the results for the HB antigen negative patients, and you can clearly see that patients who were positive for serum HBV RNA had higher intrahepatic RNA and cccDNA transcriptional activity, and serum HBV RNA correlated very highly with these markers and also with correlated antigen, but not with HBs. Moreover, the same results were obtained in a cohort of long-term NUC-treated patients that were eligible for liver transplantation and had undetectable viral load. So all these patients had a positive detection of HBV DNA RNA in the native liver, even if at very, very low levels. And the patients who had a positive serum HBV RNA quantification had higher cccDNA transcriptional activity in the liver. So as a summary, serum HBV RNA, yes, correlates with cccDNA transcriptional activity in both untreated and treated patients, but interpretation of the results may differ according to the assay that is used for the quantification, and the standardization is required. So to finish, I would like to show you this study where Gainey and colleagues analyze correlated antigen and serum HBV RNA with the Abbott test and CHB phases in North American Hepatitis B Research Network adult cohort study in 1,400 patients, and they show the clear relationship between these markers and chronic hepatitis B phases, and both markers were also consistently correlated with the liver disease marker. However, limited additional value was found for correlated antigen serum HBV DNA in the differentiation of the chronic hepatitis B phases, which is not so surprising in my opinion, but they leave an open door for the fact that these markers could help with the classification of indeterminate patients, so those patients that we cannot really classify according to the classic guidelines. So from our side, we tested the Roche investigational assay in a cross-sectional study of a real-life prospective cohort of 1,500 chronic hepatitis B patients that were recruited in 5 clinical sites between France and Italy. We have nowadays more than 2,000 patients enrolled and almost 4,000 samples collected in a biobank. So these patients were mainly European and South Africa origin with the corresponding genotype distribution. And the results of the baseline results at inclusion of the first 1,500 patients show that we have most of the patients that are HB antigen negative and half of them which are under NUC treatment. And 25% of these patients couldn't be really classified into the classic CHB phases and were called intermediate viral load because they were HB antigen negative patients who had a higher viral load that couldn't be categorized as chronic infection. So similarly to what Gainey has published, we have a clear relationship of the serum biomarkers with the phases and also a positive correlation with disease marker. And only the analysis of the follow-up with the sample will help us inform on the capacity of these markers to inform on phase transition and also response to treatment. But I wanted to leave you with a bit of a provocative data, because when we have patients that are both positive for RNA and correlated antigen, the correlation between the two is very high in untreated patients, both HB antigen positive and negative, and very high in HB antigen positive NUC-treated patients, much lower in the HB antigen NUC-treated one, probably because the levels of these two markers reach the limit of detection. But 30% of the patients that we had in our cohort had discordant core and serum HBV RNA detection. Why? What is the meaning of that? So besides the fact that there are two different assays with two different limits of detection and detected two different things, I clearly believe that we have to go in this direction and understand which type of biological meaning could be under that. So to conclude, these two biomarkers are promising surrogate markers for cccDNA transcriptional activity. We have to go on inquiring their combination. So stop-nuc studies have informed us the fact that these markers could help stratifying patients for the probability to achieve functional cure. And we still need knowledge from translational study, coupled intrahepatic and serum data. And also we have to pay attention to the fact that biomarkers have to be selected according to the therapeutic strategy. So if you want to know some more about these biomarkers and beyond, please go and have a look at the work that we published, led by Anna Krimvis and Peter Revel, which featured the November cover of Nature Reviews Gastroenterology and Hepatology. And thank you very much for your attention.